Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman, a general surgeon from Indiana. This show is tailored around the nuts and bolts of rural general surgery practice. You will find topics such as practical surgical tips, rural lifestyle, finance, training, practice models, and more. We have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. If rural surgery is your passion, this show is for you. So, now that the ChloraPrep has dried, let's make our incision. Welcome back to the Rural American Surgeon. I'm your host, Dr. Randy Lehman, and I am so honored today to have Dr. Shanda Blackmon with me today. Thank you, Dr. Blackmon, for joining.
Thank you, Randy, for inviting me.
My pleasure. And I know Dr. Blackmon from my training at Mayo Clinic. She was a thoracic surgeon. I did a whole dedicated rotation with you as one of the best rotations that I had, I got to say, in residency. And since then, you've been doing great things. And I'm so glad that you took the time to come join us on the show.
Well, it's great to join you. I love that we've stayed in touch over all the years and talked back and forth about cases. I've also enjoyed training you. You're one of the best residents I've ever trained.
Oh, man. All of our heads, we're not going to be able to get out of the room. The head's going to be too big. So why don't you start with just giving the listener a little introduction of yourself and your training path to kind of who you've become and what you're doing now, and maybe even what you want to do in the future.
Yeah, so I'm a minimally invasive thoracic surgeon. I first trained in general surgery, and once I completed my residency, I got really interested in cardiothoracic surgery. I came to Houston, Texas, where I finished my training there, and I became interested in complex esophageal reconstruction. So I did a super fellowship, needed a few more years of training, went over to MD Anderson and did a little bit more. And once I finished, I got recruited to go to a hospital in Houston called Houston Methodist Hospital. And I practiced there for 8 years, where I was chief of thoracic surgery. And I trained all of the MD Anderson residents during that time and ended up hiring my partner, who became the chief there. I decided to move over to Rochester, Minnesota, and became professor of surgery at Mayo Clinic, where you and I met. And I was at Mayo for 10 years. The weather was pretty cold, but it was
freezing.
A great hospital. Ultimately, my husband was a golf pro, really loves to play golf. My family is here in Houston, and we decided to come back to Houston. And now I'm at Baylor College of Medicine, which is where I did my cardiothoracic surgery residency. I go to multiple different hospitals, and I'm the director of the Lung Institute. So I do esophageal, lung, mediastinum, anything inside the chest surgery today. And I train residents, medical students. And a big part of my practice is innovating. I hold several patents. I developed an app that guides people for managing patients who've had any kind of foregut surgery. And I continue to do research around that. And I've developed some surgical instruments, and I've written a book called the Support Group. I still run patient-focused support groups. I've done that for 20 years, and it's very near and dear to my heart.
Well, there's also a book on esophageal surgery, right?
That's true. There is a book about esophageal surgery published by Springer. Correct.
Multiply published author. I mean, where do we start? Man, inventor. It's fantastic. So what surgical instrument, this little rabbit trail, what surgical instrument did you invent?
Well, a couple
Can we
of them.
Get it?
It's made by Scanlon. It's a company that builds minimally invasive surgery instruments. One is a vented sucker, and one is a gnarled tip sucker for decortications. And we've worked on some other devices as well.
Cool. Awesome. All right. So I have one little interesting anecdotal story before we start on training. So we had a mentorship model at Mayo, and in your rotation, I was on with fellow and then myself, but it worked out great because the fellow had done so much foregut surgery that he was kind of over it. And what he really wanted to do is the lung cancer surgery. And so we kind of divided, and I got to do a great, foregut hiatal experience while he kind of did most of the lung cancer resections. And one case, we were doing. Do you remember Jessie?
Yes, I do.
So where is she from? Somewhere in Southeast Asia.
Yes.
I want to say.
Mm-hmm.
And so she's a visiting surgeon,
right.
full thoracic surgeon for like a decade herself back home, and was visiting and watching you. Mm-hmm. And you were patiently waiting outside the room as I, was getting the case kind of started and carried on. And I'm not sure if you know this story, so that's why I wanted to say. Okay. So Jessie's standing behind me. Now she's handicapped because she can't scrub in, and so all she can do is stand there. But I used her as a resource probably more than on that rotation, because I would always be asking her, but she couldn't take over the operation. All she could do is talk me through. So I'm doing the
perfect mentor, right?
Yeah. So I'm doing this thoracic lymph node dissection, and I remember you came to me afterwards and said you had watched the video in the lounge, like down the hall.
Yeah. So we had a remote camera system where you could be at your desk and watching the surgery while you're working on a couple of other things. We also had the system where you could stand outside the room and watch through the window, because most of what I did was minimally invasive. So it's projected up on a big screen. And then, of course, being in the room or being scrubbed. And those levels of observation are frequently determined by the skill of the resident, the amount of trust we have with the resident, and all the critical portions of the surgery we're always deeply involved in.
Sure.
But I would say, like, some of the less critical parts, we want you to have an opportunity to do some independent decision making and working. Yes.
The way that it was phrased to me was, as they're checking out the degree of the lymph node dissection, that 4R lymph node resection was thorough and adequate, and most residents stop at a certain point and would not have really completed that portion. And it was like that was the compliment, right, that was given to me. And in the back of my head, I knew that exactly what I had done is I had taken it probably to the point that most residents did. And then I turned to Jessie and I said, "Jessie, what do you think?" And she goes, I think you can go a little bit further. So I kept dissecting only because of Jessie, right? But I'm not going to tell you. I'll tell you that 10 years later, but not then.
Yeah, well, I think it's really important. And one of the reasons why that's important is now when you're doing a lung cancer surgery, picking out that one positive lymph node makes a huge change in somebody's survival. If you pick up that one positive lymph node, then they're going to get some adjuvant therapy nowadays. And maybe in the old days, if we took out a lung cancer and you had a positive single node, you may or may not get any treatment after surgery. But now you're getting immunotherapy after surgery because we know it confers the survival advantage. And that's the thing that's different between today and how it was about 10 years ago.
Yep. And maybe that story helps because what we're going to specifically be talking about, November being Lung Cancer Awareness Month, we're going to talk into how I do it extensively about some lung cancer stuff. But before we do, why don't we change up our usual question and ask, why is thoracic surgery special to you?
Thoracic surgery is special to me because my grandfather died of lung cancer and I diagnosed him. And I remember when he had bleeding and what he was coughing up, and my grandmother called and we brought him to the hospital where I was a resident, and we did a bronchoscopy. And now because he's my family, I'm not allowed to do his bronchoscopy and I'm not allowed to actually work him up. But I certainly was in the room when all the testing was being done and played a role in some of the decision making. And when he had his bronchoscopy, I remember seeing the tumor inside his airway. And I remember watching the biopsy, and I remember how it felt on both sides, the doctor's side as well as the patient and family side, of making that diagnosis of small cell lung cancer. And I think this is important for rural surgeons because diagnosing early lung cancer is such a big game-changing event. And picking up on the signs and symptoms of lung cancer and knowing who needs to get screened for lung cancer is just about the best way to make the biggest difference in someone's lives. And we know all the eligible patients are not screened for lung cancer. And we do a terrible job in the United States screening people for lung cancer. November is Lung Cancer Screening Awareness Month, and we're really making a big push and an effort to get people screened heavily.
Great.
I decided to go into lung cancer surgery because of that event. It really shaped who I am. And he was diagnosed with terminal lung cancer. He had small cell lung cancer, and it was really advanced. And, as surgeons, we always want to go in and cut it out and operate. But he decided not to have surgery. And he knew he wasn't a candidate anyway, but he also decided not to have chemotherapy. He knew it was only going to buy him extra time. It wasn't going to cure him. And he wanted to die on his own terms at home in a very small rural town called Jasper, Georgia, surrounded by friends and family where they could visit, looking out the window from his home, watching the squirrels and the animals. He didn't want to be in a big city. He didn't want to be traveling back and forth at the end of his life. And so we were all at home. And I tell my patients, that was one of the best deaths I've ever seen in my entire life. It was on his own terms, the way he wanted. So palliative care is a big part of what rural medicine doctors end up having to provide in restricted communities where they don't have the same resources as big cities. And I think that is one of the most underutilized services. Our family is grateful to this day for the care that he got with at-home hospice.
Yeah, it's interesting how the situation you find yourself in as a surgeon. Mayo Clinic encounter with helping counsel patients through the end of life is different than the ability that I'm able to counsel people on end of life decisions now. Now, mostly it's done in the clinic, very, very rarely in the hospital setting, and it's with some new diagnosis, and they're seeing oncology. And oncology always recommends chemo, and they never recommend pulling the plug, like very rarely, and or not, pulling the plug, but I mean just palliative. It's less about quality of life, and it's you have a hammer, here's the problem is a nail, and it's a very how do you say this, like challenging but rewarding, but not financially rewarding, because you're not getting paid for doing this.
Yeah.
But it is one of my favorite parts of the job is helping a patient to really understand. And a lot of these patients that I have, they're very practical people with a large amount of common sense, which I think is actually rare, becoming more and more rare in the United States. But the people that live around me, they got it, and so I can explain this is what this looks like. And also I have a phrase to say, if it ever feels like we as medical professionals are doing things to you rather than for you, that might be a sign where you might want to stop. And the decision you make now doesn't have to be a long-term. I mean, everybody has their own little ways of saying this, but I guess I'm just echoing what you say, that versus, and then I wanted to say, when I was a resident, it was normally a call from the MICU because the patient's been kept alive artificially for months, and now their whole bowel is dead. You're not even talking to the patient, you're talking to the family. And I remember one other Mayo Clinic end of life discussion that I had when I was in the ICU, and the patient had metastatic cancer. I can't even remember the type. Maybe it might have been ovarian or something like that, but everywhere, was in China, jumped on a plane, flew to Rochester, stands up from her flight and saddle PE, looking for a Mayo miracle, so to speak, which doesn't exist. And now they're in my surgical ICU, and they're going to basically pass away from all of their friends and feel quite the opposite of the scenario you just described. And it's going to happen precipitously in the next few days. And you have to have those hard discussions. Those are not nearly as fun or rewarding as guiding someone ahead of time by being close to home and being there for them through, that next stage. I don't know, anything else to add to that, or?
Yeah, I mean, I think the most important thing that we as providers need to understand is when you get a palliative care team involved, sometimes, and this is published in the literature, the majority of the time, the patients will live longer more frequently when you get palliative care involved. So a lot of times people think that they're like the death squad, but they're not. They really spend time talking to you about what do you want? What are your goals of therapy? What's important to you? Some people want to live to see a grandchild born. Some people don't want to be in pain. Some people are terrified of being alone. Everyone has different things that prioritize their care. And I think that having those conversations when people feel well enough to have them takes the burden of making those decisions off the family later in life. And that's really important in support groups. You see people at different stages of disease in support groups, and you get a chance to get inside that time machine and see what it's like from the other side when you get involved in a support group. And the caregivers get to help each other. So I think my biggest advice to rural surgeons and patients in that community is when you get a big diagnosis like lung cancer or esophageal cancer, really spend time having these tough conversations about what's most important to you and really share a lot with your family. Pick a decision maker, share that with everyone, find out how to tell people what you care about and what you want, what you don't want. So I think, hopefully we don't get there. We do early screening and we pick it up when it's curable and we're not going down this pathway. But I think if you do end up with a pretty advanced diagnosis, those are things you really want to think about.
Yeah. Very good. Well, let's move on to the how I do it. And so we'll be talking, like I said, about lung cancer and maybe the best way to start is to identify the at-risk screening populations and what screening is currently recommended. Okay. And then from there, I'd like to, I don't do lung cancer, and I would say most rural surgeons are not doing lobectomies or lung cancer operations. I've done a couple VATs for benign conditions. I've done a couple like decorts and biopsies. Of course, I do thoracentesis, but that's kind of the extent of what I do. Maybe other people that are doing more, but I think what I'm doing is pretty common for my audience. And so, how should I then be involved? Because what I'm thinking of is maybe having a talk to the medical staff, and maybe partnering even with oncology or a primary care physician to bring a talk about, hey, awareness of screening. And if maybe you have other ideas as well as to what we could do.
I'm not sure if rural surgeons are involved in doing bronchoscopies, but I imagine that you would be. A lot of new technology that's coming out that is very easy to learn is navigational bronchoscopy, which is it's like playing a video game, driving a small camera out to the tumor and doing a biopsy. Sometimes doing a needle biopsy of the lymph nodes to stage the cancer. But what I would say, every rural doctor, whether you're a primary care, advanced surgeon, working in a rural community, everyone needs to understand the screening criteria for lung cancer. And we've come a long way. Some of the criteria have changed over the years. But today, we do have approval for lung cancer screening. It is paid for by private health insurance through USPSTF, which is the organization that guides that decision making and enforcement. And it is paid for by Medicare and Medicaid. It has gone through national coverage indication through CMS, Center for Medicare Services. So the criteria right now are if you're between 50 and 80 years old, although a lot of people are arguing and looking at expanding those criteria because 80 now was what 70 was 10 years ago. So if you're fit and 80 and you would be able to tolerate surgery, why couldn't you have the screening at 81? So a lot of practitioners are sort of expanding those criteria, but today what's covered is if you're 50 to 80 years old and if you have a 20-pack year smoking history. Now that's moving a little bit as well, because if you have a 20-pack year smoking history, that means you smoked a pack per day for 20 years. But what if you smoked, a half a pack for 30 years? I think we get caught up on the nitty gritty. So a lot of thoracic surgeons are advocating to say, did you smoke cigarettes for 20 years? And not get caught up on how much did you smoke. If you smoked for 20 years, that's enough. So we're working on, are those criteria going to be somewhat flexible? Obviously, right now, what's covered is if you smoked a 20-pack year smoking history. And then the last criteria is really, did you smoke within the past 15 years? Now, that's also being questioned and challenged, because if you quit smoking 15 years ago, can you still get lung cancer? Yes. And to qualify for lung cancer screening, no provider wants you to go outside and have a cigarette so that you qualify. So we're really pushing, trying to enhance the screening criteria, but not put more people at risk with radiation exposure. So if you're 50 to 80, 20-pack year smoking history, smoked within the past 15 years, you clearly qualify. Some of the organizations are dropping that smoked within the past 15 years and recommending that you go ahead and screen. So the American Cancer Society follows those guidelines as well. And they emphasize shared decision making. And the test that gets done to screen for it is a low-dose CT scan.
Yep. So let me summarize. Understanding that there's possible exceptions and you could expand, but smoking from ages 50, if you are ages 50 to 80, you had a 20-pack year smoking history and you smoked within the past 15 years, then you should get a low-dose CT scan.
Correct.
Of your
Everyone
chest.
that meets that criteria should get a low-dose CT. And
How
then
often?
Once you get that, you follow what's called the Fleischner criteria or lung RADs, and it gets read out by a radiologist. If it's a tiny little 3-millimeter nodule, we usually aren't that concerned. But if it's bigger than 6 millimeters, there's frequently some follow-up that needs to happen. And the follow-up depends on the degree of suspicion for it being an invasive lung cancer. And sometimes it gets followed and sometimes it gets a biopsy and you get staging. So working up a lung cancer can be scary for a patient, but not as scary as being diagnosed with late lung cancer. So if you don't get screened, you're more likely to get picked up with the lung cancer diagnosis late when you present with clinical signs and symptoms. And that's when it's not as easily curable.
Got it. So rate of developing lung cancer is about 1 per 2,000 per population per year. Does that sound about right?
In general,
risk of 5%
if you
lifetime?
If you meet the criteria for lung cancer screening, then the rate goes up that first year to over 2%. So if you screen 100 patients, at least 2 patients are going to test positive for lung cancer. But the true benefit of lung cancer screening and the true cures come from those next 4 years of screening. So you get screened every year, not just 1 year. And that second year, if you get picked up with the diagnosis of an early stage lung cancer or a lung nodule, that's when you really benefit from the screening. That first time, you're going to pick up people early stage, late stage, because nobody's really had any screening. But it's important, just like mammograms, that you go back year after year and get the repeat scanning to get the early lung cancer diagnosed.
So even if the lung cancer screening CT is perfectly normal, so the next time they should do that is in a year. Is that correct?
Correct.
And then when does that stop? Once you're 80 or once you have 10 years life expectancy? Or
I think it depends on when you stop smoking. If you stop smoking, then it can stop sooner than if you continue to smoke. I think you should be screened during that duration when you meet those criteria continuously. But if you've stopped smoking, then you keep getting screened until you're out of that window.
Yep. Got it. To give a little color to my practice, so I came out intending to be able to do bronchs, but I have never had to do a bronch in 5 years.
Wow.
Yeah. And part of that is because of the resources of my hospitals that I'm working in. It's a little different if you're a rural surgeon in Indiana and I'm choosing to work in critical access hospitals that don't have an ICU, right? So that's the big driver, because
Right.
don't have ICU patients, don't need to do bronchs from ICU perspective. And then for those, so basically if you've got a 1 in 2,000 per year, risk of getting lung cancer. And then, so in my community, in my county, maybe there's 30,000 people. So, the numbers of people that are going to be diagnosed is quite small. And then in my situation, Lafayette, which has pulmonology, ICU, all those things, is 45 minutes down the interstate. That's different than being in like maybe Butte, Montana. Okay. Or like, somewhere where it's like, you're going to have an ICU, you're not going to have, like in several of the places I'm at, there's very limited subspecialists. It's like primary care and a general surgeon. And so I'll do things outside of the general surgery usual scope of practice, but then I don't do like, if somebody comes in and they're very sick, I mean, it would completely overwhelm our whole hospital. And so those patients, and it's not like that far away. So then they should go kind of down the road. So that's how things
them on out.
That's how it breaks down. The labor breaks down basically in my practice. And it turns out to be like a lot of outpatient, stuff and high volume, low acuity, which honestly is fine for me. But then I can kind of consider myself the surgical gatekeeper. I know who the people are in the state who do the other certain things, and I get people, where they need to go. But just because you were saying it, I think it depends. Like probably a lot of general surgeons in rural Americas are doing bronchoscopy. I particularly haven't for so long that at this point I would probably send them, for that.
Yeah. Yeah. Well, I think, when you're screening people for your surgery, whether you're doing a vasectomy in a rural community, or if you're doing a biopsy of a lymph node, I think as a surgeon, it's important to get history for your patient. And you always want to coach your patients to stop smoking before you operate on them, because we know it affects wound healing. So if you're talking with your patients and you discover that they are active smokers, or if they've smoked in the past 15 years, that's your moment to intervene and change their lives. So then they get a double bonus, right? You give them their vasectomy and you diagnose them with early stage lung cancer at the same time.
Mm-hmm. There you go. Very good. So just thinking about those things. And colon cancer screening is the same way, Yeah. And actually, while we're on it, something that most rural surgeons, I would say, are doing is a fair amount of endoscopy, like GI endoscopy. What about screening with an EGD? When do I need to consider that?
So that's a great topic. I think if you have patients that have experienced reflux for more than 5 years, every single patient that's eligible, that is a good, reasonable candidate that has had reflux for 5 years needs an upper endoscopy. And that is to rule out esophageal cancer. There are some other new technologies coming down the pipeline. We talked about a sponge that comes, you swallow, the capsule dissolves, the sponge expands, and you pull the string and pull it back out. Some of those are close to being ready for prime time, but not FDA approved yet. But I would say when you have these new technologies, anything that can pick up early cancer is always going to be better, especially if the risk of the test is low, because esophageal cancer and lung cancer are two of the highest fatality rates with the diagnosis. Lung cancer is the number one cancer killer in the nation, more than colon, breast, and prostate combined. And the death rate in esophageal cancer, usually not as many people get it, but the number of people dying every year are the same number of people that are getting diagnosed every year, which means it's a very high mortality rate associated with the diagnosis. So early detection is definitely the theme of the day.
If you have that patient 5 years of reflux, you do an EGD and it's normal. Do you recommend them to have an EGD at any point again in the future?
I think if they continue to have reflux and another 5 years go by, definitely you should do it again.
Okay.
I think if you see anything, if they get, say, Barrett's, then you need to start following the Barrett's protocol. If you see low-grade dysplasia, you need to have a shared decision-making conversation with them about ablating, whether or not to ablate that lining to try to change it back to a normal lining. If you see high-grade dysplasia, they absolutely have to get radiofrequency ablation with halo or some type of technology to ablate that inner lining of the esophagus and try to change it to a normal lining. And then absolutely the conversation that you need to have with your patients is getting them on PPI therapy, testing them for H. pylori, treating them appropriately if they test positive, and then preventing all that acid reflux. And then, sometimes they need lifestyle modifications. They might be overweight. They need to lose weight, and that might help with the reflux. Or they might have their whole stomach up in their chest and they're symptomatic. So they might need anti-reflux surgery. All of these factors start to play a role when you start looking at people who have terrible reflux.
Yeah, I'm getting sidetracked, but this is something that's a little bit more of like my everyday, right? So naturally. So I just, a quick web search says 20% of the population has GERD. So this means that potentially up to 20% of the population should be having every 5 years EGD just for that reason alone. But then you're going to find a lot of other things. I feel like EGD is underutilized.
I think you're right. And I think the rural surgeon can play a key role in moving the dial and the health of your patient when you're doing these upper endoscopies. And a lot of people choose to have it done at the same time that they're having their colonoscopy. We call it 2-for-1. But definitely people need to meet the criteria. And so just because you have reflux, it's not necessarily an indication. It's have you had reflux for 5 years? So definitely, and one of the scariest things that I hear, I'm on the other end of the spectrum. I'm seeing people with, esophageal cancer that requires surgery and esophagectomy and reconstruction. One of the things that I hear is, oh, well, I had reflux and then it went away. Well, we know that when you have really bad reflux, that inner lining of your esophagus can change from what we call squamous to columnar. And when you get that metaplasia, that metaplastic change on the inside, and you go from a squamous to columnar lining, it doesn't burn as much. And you might not feel it as much, and you might not have as much symptom as you had originally when it was burning. And so if that burning goes away and you haven't done anything, you're not on a proton pump inhibitor, you're not on antacid therapy, and the burning suddenly goes away and you didn't get your hernia fixed, you may want to ask your primary care provider, well, I had terrible reflux and it just went away. What do you think that is? And maybe the answer is because the lining is changing.
That one's not something I think about every day. Very good point. I've got a sort of, I don't know if this is a controversial question, or I think it's a question that has had different answers from different people over time, and I'd like to get your take on it. Before we hop back to lung cancer, does anti-reflux surgery protect against esophageal cancer?
Oh, that's a great question, and it comes up all the time. So there isn't a really good large randomized trial that I'm aware of that says doing anti-reflux surgery is going to move the dial and change things. It's not standard of care for everyone with reflux. It is risky. There are bad things that happen when you have anti-reflux surgery. So typically I only recommend anti-reflux surgery for people who have started on a PPI therapy and they continue to have bad reflux symptoms or epigastric pain, or they're at risk for volvulus. So if they fail medical therapy and they still have symptoms and they're a surgical candidate, then I think they're a good candidate for anti-reflux surgery. But again, that's more shared decision-making, more complicated, discussions. I think all of us that do anti-reflux surgery remember the one case that didn't go the way we wanted and someone had a bad outcome. And you always kind of need to remember those cases in the back of your head and remember it's not a risk-free surgery. So the risk-reward benefit has to be worth it.
So we talked a great deal about the screening. Honestly, the workup, I feel once the screening happens and you find things. It's pretty familiar. Bronchoscopic versus CT guided biopsy. Staging. Could you discuss staging a little bit for me?
Yeah. So what we do when we do staging of really any thoracic cancer is we go wide and focus narrow. And that means we look for metastatic disease first, rule that out, and then do procedural staging. You don't ever want to do a navigational bronchoscopy, an endobronchial ultrasound with transbronchial needle aspiration in a patient who has brain metastasis or has, disease in their liver. So the first thing we start with is a CT. We look to see if there are big lymph nodes. We look to see if there's disease outside the chest. We look to see if there's disease in the abdomen and the liver. And then we go with a PET scan. And the PET scan can give us an idea of how FDG avid or hot the tumor is. And that just, FDG is a sugar, form of sugar. Anytime you have a high metabolic turnover of cells, the sugar concentrates and lights up bright on that area of the scan. So we look to see if something typically has to be bigger than 0.8 or a centimeter to be bright on PET scan. But if you have a tumor that is about a centimeter and you get a PET scan and you see tumor lighting up outside of the chest or in the lymph nodes, that is something you have to investigate. And we usually want to get a biopsy. So if there's metastatic disease, you then go through the metastatic workup. Depending on how somebody presents, you may or may not also want to get brain imaging to rule out metastatic disease to the brain. We follow the NCCN guidelines for working up a patient. But once you're able to get metastatic disease ruled out, then you start working on the staging inside the chest. If there's just a tumor on one side and it's a big tumor, or you're worried about it's central, or you're worried about disease in the chest, then you might do the endobronchial ultrasound, needle aspiration of the lymph nodes. You want to check all the N2 lymph nodes, station 2R, 2L, 4R, 4L, and 7. And those are the nodes that you want to know if there's cancer or not. Now, today, it's changing some. If we know that there's disease in the lymph node, we might treat with chemoradiation, or we might treat with chemoimmunotherapy. Chemoimmunotherapy now is the standard of care for patients who have some type of advanced disease before surgery, especially if it's in the lymph nodes. So there are new clinical trials that are coming out almost daily. By the time you look at one guideline, it's extinct and a new guideline's coming out. But in general, we need to completely stage our disease, have a multidisciplinary tumor board meeting, and do shared decision making, go through the up-to-date NCCN guidelines, and offer patients upfront therapy to try to reduce their burden of disease before we offer surgery if it's locally advanced.
Thank you. I have a few quick hits follow-up questions. What are the most common places for lung cancer to metastasize? Number one would be thoracic lymph nodes.
Yes.
Right? And then what?
So then it might go to the other side. It can go to the liver, it can go to the bone, and it can go to the brain. Those are the main places that you're going to see lung cancer metastasize. Very
unlikely to go to the extremities, right?
Very unlikely.
So, and if a person, when you're, the reason I'm asking this is in the point of staging, you obviously don't do a PET scan of the brain. So you do a brain MRI if you think that they might have mets to the brain. And you only do that if they're having neurologic symptoms?
But you have to do a very thorough neuro exam. And if you don't, they should have brain imaging.
So, okay, fair enough. So, and then the other thing is, I would
say there are some institutions that do PET MRI instead of PET CT.
Okay.
And in the cases where a PET MRI is performed, the brain imaging can rule out metastatic disease without having to have separate brain scans.
Sure, that makes sense. This is something you don't think about as a resident. That's why I'm asking this question is there are, to my knowledge, essentially two type of PET scans that you may want to do, looking for mets throughout the body.
Mm-hmm.
One would be a skull base to mid thigh, and one would be a whole body.
Yeah.
Right?
So
is there anything else besides that I'm missing?
Well, there are multiple different types of PET scan. You have a dotatate PET scan and you have an FDG PET scan.
Yeah, I guess I'm talking about FDG PET CT scan for cancer staging, whether it's lung or otherwise. And I think mostly what you would get is a skull base to mid thigh, right?
Correct, because the whole brain lights up on a PET scan. Right. So skull base to mid thigh is adequate for lung cancer screening. Correct.
And you don't need the extremities, so you're not doing the quote unquote whole body. Because I ordered a whole body one, and then I get radiology call me, do you really want a whole body? Yeah. That's why I'm trying to share
sarcoma, an extremity PET would be indicated. Yeah.
Or something like, yes, obviously take care of advanced skin cancer, that's melanoma, stuff like that, all that. Okay, very good. Thanks for letting me go down that.
And then I just want to add one more thing.
Yep.
For lung cancer, genetic whole genome exome sequencing, genetic testing is so important because we now have data that if you have certain driver mutations, fusions, alterations, deletions, those need to be identified early because early delivery of therapy can save lives. So what that means is if you have an EGFR mutated lung cancer, you're going to treat that very differently than if you have a wild type lung cancer. If you have an EML4 ALK fusion, that will be treated very different than a wild type lung cancer. And so identifying these driver mutations is very important and a very important part of early evaluation of lung cancer.
Interesting. And not also with the smoking influence, not something I would have necessarily, thought of.
And
great.
You have a lot of different types of lung cancer. You have carcinoid tumor and you have well-differentiated or poorly differentiated, typical, atypical. If you have atypical carcinoid tumor, then getting an FDG PET is good. If you have typical carcinoid, then maybe, and you think it's metastatic, a dotatate PET is indicated. And there is some therapy called lutetium that can be used to target that metastatic typical carcinoid tumor. Carcinoid typically doesn't really respond to other types of treatment like radiation. And then if you have lung cancer, you might have squamous cell lung cancer or adenocarcinoma or small cell lung cancer or large cell lung cancer. And all of those behave differently and are treated vastly differently. Most of the genetic mutations, fusions, alterations, deletions that we were talking about that are actionable driver mutations exist with adenocarcinoma.
Is smoking the most common reason for all those types of lung cancer that you just mentioned?
It is the majority. There are different parts of the world that have different rates. Asia has a higher proportion of genetically derived lung cancer or environmental exposure compared to the United States. But certainly radon, environment, different radiation exposures, people who had mantle cell or mantle radiation for Hodgkin's lymphoma when they were young, or women who are survivors of breast cancer who had radiation, those are patient populations that now are at high risk for lung cancer. Mm-hmm. It's not just smoking.
If you take all the patients, is the most common type of tumor a metastatic tumor?
That's a great question. I think the number one tumor in the lung is a metastatic tumor, and that's called a secondary lung cancer. And then you have primary lung cancer. So colorectal cancer very frequently goes to the lung. Sarcoma goes to the lung. There are definitely specific types of cancers that go into the lung. The lung is the filter of the body.
Yep, sure. And maybe if you're willing to take us back to med school for just a second, and the types of lung cancer, like carcinoid, small cell, and then the various types of non-small cell. What cell did they start from?
Wow. Okay. So you have type 1 pneumocytes and type 2 pneumocytes. And you have different ways that it develops from like a mutation. You have, if you have like P53, ROS1 mutation, you can have different types of lung cancer than if you have an EGFR mutation. But basically, you've got epithelial cells that sort of line the respiratory tract. And then you have, those are like bronchial or bronchiolar or alveolar epithelium. About 85% of non-small cell lung cancer comes from that lining. And I think a minority, like 10 to 15% of small cell lung cancer comes from those types of cells. So adenocarcinoma, and you're really stretching my knowledge here.
Yeah, and I'm sorry to put you on the spot.
Comes from the type 2 pneumocytes.
Okay.
But squamous cell really kind of comes from like those basal cells coming from the bronchial epithelium. Large cell carcinoma is very different from adenocarcinoma or squamous cell carcinoma. And that's really, I think that's derived from undifferentiated epithelial cells. And those can either come from either adenocarcinoma or a squamous lineage. Small cell lung cancer, and I think the only reason why I know this is because I looked it up when my grandfather got diagnosed. Those really come from neuroendocrine cells, or what we call Kolchitsky cells. And those are like amine precursor uptake and decarboxylation system. So those APUD or Kolchitsky cells are the origins of how we develop small cell lung cancer. And those are really more often central near the main bronchi. And that's why when you get diagnosed with, we used to call it oat cell carcinoma. When you get diagnosed with small cell lung cancer, it's more frequently spread. So we have a different staging system than adenocarcinoma or squamous cell.
Okay.
I think it's about the extent of my knowledge on the origins of lung cancer.
And then carcinoid tumor in the lung, much like carcinoid tumor of the appendix or other places, comes from a neuroendocrine.
Yes. And it's sort of on a spectrum. You know, you have small cell lung cancer. It's also a neuroendocrine tumor. Carcinoid is a neuroendocrine tumor. You can have single focus of neuroendocrine tumors in the lung, just a single carcinoid tumor, or you can have a disease entity called DIPNIC, which is diffuse multifocal carcinoid tumors in the lung.
Very good. Okay, let's leave that behind us.
Here goes the basic science.
Sometimes it helps me to think, like in some of this stuff I didn't even realize until like after the fact. I'm like thinking about it, and like for example, Barrett's, like it helps to know the underlying cell type. And then I treat a lot of skin cancer. And so to be able to explain to people from a basic science perspective, the difference, obviously basal cell, squamous cell, melanoma, totally different, cell origins. It kind of helps you think about it. Anyway, let's talk about treatment. And then if there's anything, I have one other question, which has to do with my upcoming board recertification. So first, let's talk about treatment.
Okay. Well, the treatment for lung cancer is so complicated nowadays. I would say in general, you want to go to the NCCN guidelines, right? Now, treatment depends on whether you have non-small cell or small cell. Small cell is almost exclusively treated with chemotherapy or chemoimmunotherapy. The only type of small cell that's treated with surgery is early stage, tiny peripheral small cell. Honestly, that you thought was non-small cell and you accidentally took it out and you later on found out that it was small cell. Sometimes you might know, but if it's just got to be tiny and peripheral and not in the lymph nodes. Now, the way that we decide how to treat lung cancer depends on, like I said, that mutation analysis. You want to get early genetic testing. We look for something called PD-L1 status. That really helps us to know if people will respond to immune checkpoint inhibitors, which is really what I would say is moving the dial the most with lung cancer. So it depends on histology. It depends on the stage. It depends on your molecular genetics. And then it depends on like your performance status. If you're always in bed, you might not be fit to have surgery or intervention. And then it depends on if the tumor is resectable or not. So early stage lung cancer is most frequently treated with minimally invasive surgery after staging. If it's stage 1A, we go straight to surgery usually. For non-small cell lung cancer, not metastasized to the lymph nodes. Stage 1B to stage 2, that's where it might have gone to the lymph nodes or it's a very large tumor. That's where we consider treating with some type of treatment either before or after surgery. And we always want to try targeted immunotherapy. So if it's an EGFR mutant, we offer them osimertinib. And the osimertinib was really defined in what was called the ADURA trial. So if you test positive for an EGFR mutation, you want to get that patient on osimertinib as quickly as possible. And then we look at PD-L1 status, and the Empower trial taught us a lot about that. And typically those patients get atezolizumab. And those patients are more frequently going to be treated based on their stage and their genetics, slightly different than those people that don't have those mutations, the group that we call wild type.
Those people also getting real chemo in addition to those
and then
targeted therapy?
The advanced stage, if you're stage 3A to stage 3B, those people typically have tumor that's gone to the mediastinal lymph nodes. And if it's resectable, surgery might still play a role. But the Checkmate 816 trial came out, and that really taught us that moving the dial with neoadjuvant nivolumab plus a platinum-based chemotherapy is the best way to get improvement. The Pacific trial really taught us that if they're unresectable, they get concurrent chemoradiation and then consolidation durvalumab for a year. If they are resectable, they might get nivolumab plus platinum-based chemotherapy. That's the Checkmate 816 trial therapy regimen. And then they get evaluated to see if they've had a pathologic complete response and if they benefit from surgery. And then the last group is metastatic. And the metastatic tumors are still changing too. MD Anderson group published a really interesting paper a while back looking at people who present with what we call oligometastatic disease. And those are patients who have one met to the brain, one met to a mediastinal lymph node, one met to another part of the lung on the same side. And those patients do live longer if you treat them with curative intent for all sites of disease. And now that's oligometastatic, only one site. They might have more disease outside of those sites. And in that case, it's considered truly metastatic, not oligometastatic. And we might treat them with what we call definitive treatment, which means we're never planning on surgery.
What about oligomets to the brain?
If you have a single oligomet to the brain for the past 10 to 15 years, we've always treated those patients with curative intent.
And is the brain treatment surgical or radiation?
It depends on the location, the patient's performance status, the other comorbidities, and what's going on in the rest of the body. But more frequently, it's treated with stereotactic brain radiation.
Yeah. Okay. And the most common, so these, jump back just real quick. So the patients that are early, non-metastatic, small, stage 1A lung cancer, straight to surgery. Do they get follow-up chemo or anything else? It depends.
If they have incidental lymph nodes that are positive, then they get treatment after surgery. If they have incidental tumors that are discovered in the lung, that advances their stage. So it depends on what they come out with pathologic stage. If they are a resected clinical stage 1A lung cancer and they come out with a pathologic stage 1A lung cancer, they are just treated with surgery and they don't need any more treatment. But if they end up with more disease than what we thought they had, then they'll get adjuvant treatment. And that depends on what we find and what the genetics are of what we find.
Yep. And then 1B, which would be a big tumor, and 2, which would be Mets to the lymph nodes, generally.
If you have metastatic disease in the lymph nodes, you're almost always going to be offered some type of treatment
neoadjuvant
after. Yeah.
Well, it's neoadjuvant, right? For the most part?
If you know clinically, yes, you get neoadjuvant therapy. You want to get that before you get surgery. If
Does anybody get
discovered after
radiation?
surgery, then you get adjuvant.
Does anybody get radiation before surgery?
So in the past, we used to give neoadjuvant chemoradiation for stage 3A lung cancer with intent to go to surgery. Today, that's changing, right?
Okay.
So now it depends on what your genetics are. That would change it. It depends on if you are resectable. Typically, if we know that you have 3A disease, you might get the Checkmate 816 protocol, which is nivolumab with the platinum chemotherapy doublet. Or if you're unresectable, then you get the consolidation durvalumab after concurrent chemoradiation. So you would still get chemoradiation and then adjuvant durvalumab for a year. And that's the Pacific regimen.
So some people do, but it's like just nuanced situation,
it's very
more advanced
nuanced nowadays.
And it's not those people that just have a couple Mets to the lymph nodes. And then last question on this is, and what I really love to talk about and how I do it is normally how you actually do the operation, how you hold the instrument, how you position them, how you make your incisions. But we're spending a lot of time on this, which is, it's totally fine. And it's actually just stuff that I mean, it's, you can't know it all. So asking from a, entry level perspective is kind of where I'm at. But if you're at if you're getting stage 1B, stage 2, you're getting neoadjuvant chemo and your targeted therapy if you're a candidate for it. Or are you usually getting...
You might just get targeted therapy and not chemotherapy if you're an EGFR mutation or if you're EML4 ALK. So it just depends. It just depends.
Okay. Well, what I was asking is what chemo are they usually getting? Is it a single agent like a cisplatin or carboplatin, or is there some other chemo as well?
It's still typically cisplatin doublet or carboplatin. Mm-hmm.
Okay, got it. I don't know if we want to.
Do you want to talk about surgery?
I mean, how much time do you have?
I have all the time in the world. I'll tell you, one of the things that's really interesting as a thoracic surgeon who loves to operate and loves surgery, I feel like at our meetings, we hardly ever talk about surgery now.
Yeah.
And I would say surgery is more important now than ever because as a thoracic surgeon, all of this immunotherapy totally screws up what's going on in the chest for a surgeon. Everything is sticky. The lymph nodes are harder to get out. The tumor is harder to get out. We have things that we call pseudoprogression, which is where the immune system attacks the tumor. And imagine this big inflammatory response is like a bomb going off inside the chest. And now we're supposed to go in and do this surgery. So I think what used to be an early lung cancer that would go in and remove, and there weren't a lot of adhesions and the lymph nodes were easy to pluck out, those days are gone. When we are doing more lung cancer screening and we're diagnosing more stage 1A lung cancer, certainly we're going to continue to see those. But more often than not, a larger proportion of our patients are going to be presenting to us after chemoimmunotherapy or immunotherapy. And in that patient population, there's going to be more inflammation, more tumor response, more stickiness of the lymph nodes, more adhesions, and a more difficult surgery, maybe even more surgical complications.
So here's my other question about my boards. So I have to do the, 40 question open book online test. It's open right now. I have to take it. What if you were going to give me, say 5 hits that are going to show up on boards for a general surgeon that I need to know, maybe things that have happened in the last 5 years or something? How do you think it's going to show up on general surgery boards?
General surgery boards. So the most important thing for lung cancer that people taking their general surgery boards need to know is that we are now doing genetic testing and we are completely staging people, and we have to give neoadjuvant therapy as indicated. So I think that would be one of the most important things that people need to know. It's no longer, only taking people with stage 3A for neoadjuvant therapy and operating after they've completed therapy. It's anybody with 1B to stage 2 that now are the new group that's going to need something different done before they go for any type of surgical resection.
What's the size difference from 1A to 1B? Is it 2 centimeters?
It's 3 centimeters.
3 centimeters. Thank you.
Yeah.
Next segment of the show is the financial corner. Do you have a money tip for our listener?
Yeah. So I think, one of the biggest financial things that I really think has made a big difference for us is the free gift that you can give to your children and establish a Roth account. It's tax free, and it's something that you can just automatically do and put away. Building the ability to save money early on, always putting 10 to 15% away and saving it for retirement is nothing that anyone would regret. Sometimes it's hard to put that much away, but I think I believe in when I am investing, I take a small amount and do high risk and another amount for safe. And then with that high risk portfolio, you never want to look at the week to week or even the year to year. What you really want to be looking at is the average trends over a series of years. If the economy starts to tank and you pull all your investments out and then you start doing rapid movements, I think you put yourself at some risk. And so part of good investing is having the confidence to stick with your investment portfolio, making sure you don't put all your eggs in one basket. And if you've got some percentage of your investments into a risky portfolio, not making rapid wiggle changes, rather more slow, methodical, more than year to year changes.
Yeah. Love it.
And then
nobody has said anything.
Me a question about like the staging and the size for lung cancer, but we didn't talk about, there's T1A, T1B, T1C, and that's kind of the difference between the 7th edition and the 8th edition. So everybody knows that T1A is less than a centimeter. T2 is where you're getting bigger than 3 centimeters. But there's now T1A, T1B, and T1C. So T1A is a centimeter or less. T1A is 1 to 2, and T1C is 2 to 3. So T2 starts at 3 or bigger.
Okay. Let me say that again so I've got it. T1A less than a centimeter, T1B 1 to 2, T1C 2 to 3, and then T2 is greater than 3.
Yeah.
Sound right? Okay.
Yeah. I just want to make sure. And T3 is if it's bigger than 5 centimeters.
Nobody has said on the show yet about gifting to your kids for an IRA. So I have 2 follow-up questions. Number 1, do you have someone who records these gifts for you? Because basically you have right now in 2025, you have a lifetime gift tax exemption, which is $27.98 million for a couple, or half of that for an individual. Mm-hmm. And so really, you should be recording that, and then that comes off your estate later on. In terms of anything above that, then would be subject to estate tax. And all that can change. The thing is, it most likely will change by the time you die. So it's kind of hard to plan. But I was just wondering, do you have a person or a process to track those gifts?
Yeah. So you can't directly gift an IRA account to a child. So that's not legal. It has to be owned by the individual whose name is on it. And you can't transfer or gift a part of your own IRA to someone, as far as I know. But what you can do is you can fund your child's own IRA if they're eligible. So the IRS, I think, only allows IRA contributions to be given from earned income, but you have to set that up in advance. So unearned income like gifts or allowances or investment, it doesn't qualify. So you can gift the money to your kid, but they must have earned the income to make the contribution.
Okay. So then how do your kids work?
So if you have a child that's under 18, they can't open their own IRA, but we opened up a custodial IRA. That's called a minor Roth IRA, and we opened it on their behalf. And so you act as the custodian for your child, but the child is the legal owner, and you can contribute up to the child's earned income or the annual IRA limit. The 2025 limit was $7,000 per year.
Mm-hmm. So, but do your kids then have to show that earned income? And so do you, like, for example, with my kids, I sent out a big mailer with my kids' faces all over it. They do videos and stuff for me on like our farm website and also on the Liberty Clinic website and things and Facebook. And so basically I pay them for that. I pay them for some sort of marketing. I was just wondering, do you have your kids like working in a sense in any capacity like that before they actually go and get their first maybe like outside of the house job?
I have not done that, but I can say my son, Sam Blackmon, the day he turned 14, he got on his skateboard and went to McDonald's and without telling us, got a job. And he was frustrated that he couldn't have what he wanted, and he wanted to be able to get things that he wanted that we said no to, mostly things for his skateboards. And so he was highly motivated financially. So he and the McDonald's that I'm talking about.
Sure.
He went right down there and he worked at McDonald's for the better part of 14 to 15 years old. Now, Jake got a job bagging groceries at the Hy-Vee right next to McDonald's. So my children really enjoyed working. They worked as lifeguards. They worked at concession stands. They almost always had an odd job. And a lot of times we weren't paying them. They were getting their own money. So say you have a 14-year-old like Sam, and he's working at McDonald's. He makes $3,000 from that money. He can put it into a custodial Roth IRA in his name, and that's his earned income contribution. So they won't pay tax, and it will grow tax-free potentially for 50 years.
Right.
Now, trying to talk a 14-year-old into putting money into a Roth IRA, it's a different story.
So that's where you make it up with a gift.
Yeah, you can make it up with a gift. Yeah,
but it's not the gift money. They're living off the gift money. They're buying their skateboard stuff with the gift money. They're taking their earned income and putting it in. That answers my question. So thank you. And then the last question I was going to ask you kind of answered already, but I've got a 6-year-old and an 8-year-old. So my question was, do your kids know about these IRAs that you're setting up for them? And then maybe better question is, at what age is the right time to tell them?
I think it depends on the amount, and it depends on the type of account. So I hope my children don't listen to this podcast, but my mother has been putting money into an account that matured when they turned 21. My twin boys are now 21, and they have full access to those accounts. Now, we haven't told them that they have full access to those accounts. And we we get money withdrawn out of those accounts to help pay for college. There are other types of, like our will. We just redid our last will and testament. And in our will, there are certain gifts that won't become freely accessible to children, that they don't become have full custody of their own trust until they're like in their 30s. So there are different types of regulations that you can put on gifts to your children. And I think that's, it's really important to be discretionary about what you tell your children that you're doing for them, depending on how responsible you think they are.
Right. I agree. It's almost like you don't want to give them it's like you don't want to give them anything until they don't really need it. That's the hard part about raising kids. Like you want to give them everything and, give them a leg up, but it's almost like that rite of passage to become successful on their own. You're crippling them if you take that away from them. I mean, I don't know. That's summary, but
no, I worked as an artist for a year and nobody would buy my paintings. I don't think I was very good. And I was living off of macaroni and cheese, and my mom would have to buy a painting for me to pay rent. And I was pretty hungry and poor and sad, and it gave me that fire in my belly. And I was like, I think I'm going to try a different job. Maybe I'm going to go to medical school. I definitely would not have had the same drive that I have today if I hadn't felt that pain. So it's like, how do you give your kids that pain of, the burning in their stomach to want more? If your kid always has everything laid out in front of them, they're not going to be hungry. They're not going to know, not that you should starve your children, but you have to let them suffer a little bit to get that drive.
Great. I love it. Classic rural surgery stories. Did you have another story that you wanted to share with us besides that story about your dad that is maybe just something crazy that's happened recently or in your practice that it's just, you would not believe this story ever happened?
Well, I will tell you the best thing that happened to me today, and it's one of my favorite things in the world that happened. I try to call my patients as soon as their path report comes back. And 30% of the time when we take out an esophageal cancer, all the cancer is gone. Now, my big dream is that we're going to come up with something like cell-free DNA or some type of a blood test that tells us when all the cancer is gone, so we don't put them through a big surgery. But when we put someone through esophageal cancer resection, it's removing their entire esophagus, part of their stomach, stapling the stomach in the shape of a tube, pulling it up and connecting it. It's a pretty brutal surgery. And sometimes people find out that they had pretty advanced disease and it's devastating news and they have to take treatment after. But this morning, as I was drinking my first cup of coffee, I got online and I looked up my test results for my patient, and I discovered that he had what we call a complete pathologic response, meaning he went through chemotherapy, and the Matterhorn trial has just come out. It shows that for patients who have a certain type of esophageal cancer, if they now get durvalumab added to the chemotherapy, they have a better response. And this patient had it. So he had a complete pathologic response. He had flat chemotherapy plus durvalumab therapy, and all of the cancer was dead. We took it out. It grew into his pericardium, the sac around his heart, and we had to take even that out. And now today, he is about as cancer-free as a human can be, but I won't use the word cure. It's been completely resected. All the margins are negative. We did a radical resection. We took out a huge part of the sac around the heart in conjunction with the esophagus. He's not had a leak. He's at home recovering. He's feeling great. And I just can't wait to see what happens to him. It just made my day. It's like the best way to wake up and have your first cup of coffee is seeing all of the things that we do coming together to give that amazing response. The only thing better than that is picking up an early lung cancer and taking it out.
Yeah. That curing cancer. Why would you want to be a thoracic surgeon besides that?
Yeah, that's it.
That's beautiful. Last segment of the show, resources for the busy rural surgeon. So how can people use, first off, your resources I'd like to hear, and any other resources that you think would be useful for a practicing rural surgeon as they come across these things like colon cancer and esophageal cancer?
So AJCC staging is really important. I'm on the education committee for AJCC, so it's very important that you have access to staging that's up to date. We have the 8th edition, and now instead of having one moment in time where we switch from 8 to 9, we're going to have a rolling enrollment where different tumor sites are going to have updated staging. NCCN guidelines are also really important when you're looking at doing the right thing for the right stage at the right time. Involvement of palliative care and palliative resources for that multidimensional approach. And I think, when it comes to other guidelines, a lot of our societies have guidelines. I think the most important thing is to look at what is being approved by USPSTF, what's being approved by CMS, and at a minimum following those guidelines.
Okay. AJCC staging, how do you access it?
Through the American College of Surgeons, and any rural surgeon should have access through that mechanism. Your cancer committee within your hospital, if they follow the Commission on Cancer standards, or if they're submitting data to the National Cancer Database, NCDB, they would have access to AJCC staging.
Okay. And then on the NCCN, just for like residents, I would say, you get a free plug in your email and create an account. So I would recommend to a resident do that early and often, and then review any cancer that you come across. That's great practice for your own practice later, to just look up. If it's just you, the best way to be a trainee is kind of just imagine that all of a sudden all the other doctors just died, and then it's just you and the patient left over. Now, what are you going to do? And come up with your best guess, and it'll probably be wrong, but then making a wrong choice and then hearing why it's correct, not only will you learn it better, but your staff is going to be impressed because you actually thought about it. You tried.
Yeah, that's so impressive to me. The worst thing is just to have somebody who comes along for the ride. I want people to try to offer solutions. And even if they're wrong, it gives an opportunity to teach.
Yes, exactly. So this has been a great course through what is a very important topic, with the number one cause of cancer-related death, which is lung cancer, and a very timely point in November to be able to go through this. So thank you very much for joining us, Dr. Blackmon. It's just been my pleasure and honor.
Thank you. Really been a true honor to be with you. Thanks, Randy. So great to see how great you're doing. Love your podcast. I've listened to 3 this morning.
Very good.
Thank you.
All right. Well, and thank you very much to the listener as well for this episode of the Rural American Surgeon. I am your host, Dr. Randy Lehman. We will see you on the next episode of the show.